Board meeting. We are the advisory board for the Board of Supervisors. We hold this meeting on the fourth Thursday of each month, and it runs from 12:15 until 2:15. We meet in person at this building, 507 10th Street. This is a public meeting and everyone is invited to attend. Members of the public may participate remotely. The minutes and the agenda can be found by Googling Humboldt County Behavior Health Board. You will find such information within a list of committees. We provide time for the public comments early on the agenda, and public comments need to be limited to 3 minutes and pertain to matters related to behavioral health. We ask you to make your comment in a respectful manner. Please note that this meeting is being recorded. If at a time you want to make a public comment that's very uncomfortable for you, we'll just stop the recording for you to share your public comment with us. If you have questions about those, you want to send a different comment, you can send it to one on the executive committee or to any board member. So with that, I think we can start the roll call.
Alyssa Norman,
Here.
Laura Montana,
Here.
Steve Madrone,
Present.
Tim Ash,
Sure.
Jim Doty,
Here.
Madison Flynn, Allison Tans, Debbie Hartridge,
Here.
Colleen Broderick,
Present.
Annette Kellerman,
Here.
Brent Price,
Present.
Gardner Carlson,
Here.
Oscar McGowan,
Smokey Present.
Kate Smith, Lenore Ramirez.
Lenore here? She was approved by the Board of Supervisors. And that makes you, makes you an official member. All right, we've done the roll call. We have, what is it, 9 people there, Joe? We have a 4?
Yeah, we have 10.
Okay, 10. Okay. Great, then we'd like to have staff check in, let us know you're here, maybe tell us what your job is. Let's do this with everybody in the circle here, and then I'll go, so it's not too confusing, and call your name off, you can tell us who you are. If I make a mistake, you can correct me. All right, stand here. You go.
Hi, good afternoon, Amy Bossler Rogers. I'm the Behavioral Health Director.
Hi, everybody. My name is Oliver Gonzalez. I'm a program manager for the Mental Health Services Act here at Behavioral Health.
I'm Jeremy Nelson. I'm the Deputy Director over Children's Behavioral Health Services.
Thank you, Jordan. Oh, yeah, you're not. Other members of staff?
Hey, Tim, do you I don't know, I'm kind of a member of the staff, but kind of not, I'm contracted with Humboldt County Mental Health as family
Let
liaison.
me ask Emmy if you're part of.
Yes.
Yes.
Okay. I've been asking. Leah and Amy.
You can, Leah.
Good to be here.
All right, let's go with the staff who are with us by Zoom. Jack.
Hi, I'm Jack Brazil, Deputy Director for Behavioral Health.
Paul.
Hello, everybody. Paul Bignacki, Deputy Director of Behavioral Health.
Alex.
Hi, my name is Alex
I'm Alex.
Childers. Oh, my bad.
Oh, I'm Alex Oliveira. I'm a MHSA and QI admin analyst.
All right, I'm just calling names as I see them. Sonia.
Hey everyone, Sonia Lovey Boyd. I supervise the Humboldt County Transition Age Youth Collaboration and the peer coaches at the T Division, and I use she, her pronouns.
Nancy.
Hey, I'm Nancy Stark. I'm the Legislative Manager for DHHS, she, her.
Thank you. Christine, please staff. Introduce yourself. You're muted. Can you hear me? Okay. All right, at a later time, maybe. Sharon.
Hi, I'm Sharon Wolf, Legislative Analyst at DHHS. Good to see everybody.
Oh, Alex, another Alex. I didn't see that.
Are there any other Alexes? Okay. I'm Alex. My pronouns are they, them, and am. I am a peer coach at the Humboldt County Transition Age Youth Collaboration.
Great, glad to have you with us. Is it Cerebus? I can't hear you.
Hmm.
I don't know what's going on, whether it's your, could be your volume.
Can you hear me?
Sometimes. Yeah.
Okay, my name is Cerberus. My pronouns are he, him, and am, and I am a community member here to give my comments and also listen to the meeting.
Sharon. Okay, Connie. Introduce yourself.
Hi, Connie Beck, Health and Human Services Director. Good to see you.
I have two Sharons in front of me. Are you both members of the public or Sharon the first one?
First person is staff, another second chair.
Okay, I'm Sharon. All right. Katie, Drew, are you staff member here? No, I understand. Okay. And then Sharon Benda, I know you're a member of NAMI and a member of the public. Let me make sure I got every staff person introduced. I did the best I could, and I think I did. What do you think? Thanks.
Good job.
Hi,
Okay.
I'm Christine Messenger. I'm with the communications group at DHHS.
All right, thanks. Good to hear from you. So let's introduce members of the public who are here, and for their public comments, I want to start with those who are here in person. Are there any members of the public? You don't have to introduce
I'm a
yourself.
member of the public.
Okay, good.
My name is Judy Pasco and I'm just here. I have a son who has some mental health issues, an adult son. And I just found out about this yesterday, so I didn't have an opportunity to read the whole thing, but I'm curious.
Great, glad to have you with us. Is that what you wanted to share with us? It's all time for.
I know, unfortunately, I didn't have time to read with the late finding out about it, time to read the whole plan. But I'm curious to.
We're
learn
glad
more.
that you're here.
Hear other public comments.
Right, any other from the public or in the room? Let's go then to public members who are on Zoom. I want to go, there's a Sharon Benda. Why don't you introduce yourself? You're muted, Sharon. Well, okay, then Sharon, I see connecting to audio. How are you doing, Sharon?
I'm not sure about this.
Are there two Sharon?
Yeah, you're probably having trouble with your computers.
Okay, when you get a chance to speak to us, we'd love to hear you, of course. And Katie Drew?
Yeah, hi, I'm the behavioral health nurse liaison here at St. Joe's and also Redwood Memorial. And I mostly just wanted to listen in because definitely the three-year plan affects us here in the community as well. And so just looking to hear all the great information that everybody has to share.
Okay, thank you. You want to introduce yourself, lady, who's just walked in?
Hi, Tim, I'm Laurel Johnson. I'm an analyst with the DHHS admin.
Good to see you. It's always a pleasure.
Good to see you.
You. So I want to invite public trying to handle all of this.
Adjustments to the agenda is number 3.
Would you like to move on?
I would like to do adjustments.
All right, let's move on to public comments and do adjustments.
Adjustments to the agenda would be, I'd like to move the May's Mental Health Month Community Service Awards up before public comment.
I blew it, didn't I?
No, you're fine.
Thank you.
You're welcome.
We'll forgive you.
It's all
Thank
right.
you. All right, let's go. That would make it 3.5. And so let's start. Debbie, do you want to introduce your person and bring that person forward?
Okay, I didn't, yes, I would gladly. Yeah, oh, yeah, it's a surprise.
It's another walk for you, Leah.
I'm a little confused. Is the public comment section over?
Or somewhere. Or do we just stand?
We move the agenda to give you time for those comments. Thank you.
Should we come somewhere, Tim, or stand here?
I think you should, so we can applaud you, see who you are
Up front?
up front.
Is that okay, Leah?
I'm fine.
Okay.
I'm good.
So, I already introduced myself. This is Leah Nagy, who I nominated for one of these community service awards because I've known her for many, many years as a member of NAMI, and she is really the big force behind one of our most important services, Well, she's the big force behind a lot of things, but, but one of our most important community services with NAMI is, which I'll talk about a little bit, is the family support groups, which since Leah has been running these groups, with help from others, but kind of the force behind them, I would say, those groups meet every week. 3 times a week. I mean, every week. This is a volunteer. I mean, I know you're not totally a volunteer, not totally, but there's a certain portion.
I never pay my bill.
Yeah, I know. There's a certain portion of you that is doing this. These are NAMI sanctioned family support groups, which means people who lead them are trained by NAMI with a certain, I guess you could say curriculum. So anyway, so these are for family members. There are 2 in Eureka. There was 1 in Redwood. Redway. One in Redway. And I mean, it's that just that commitment to being there and making sure these groups happen every week means a lot to people. And I did attend, I've attended these groups myself. I'm a family member. I just attended one on Monday, and there was a couple there who said, thank heavens for these groups. They got us through a really rough time. And they were thanking everyone in the group for being so supportive. So that's the kind of feedback that comes in. There's just something about being able to share your experience with others who have a similar experience. And really quickly, I mean, this is one thing that Leah has been doing. She's also president of NAMI. She's a public speaker. And I guess the thing I put in my nomination for that it stands out, another thing that stands out is her willingness to be public about this illness, which is hard to do. And I understand that very personally. It's hard to do. And she has been on panels, she's been in the media, she's been on the radio, key TV series about suicide, speaking publicly about mental illness, how it's affected her family, and how, you know, how you can, life goes on and you can be the best you can. So flowers for you.
And the certificate.
And the certificate.
You and I have worked a bit together and on NAMI and in the support group, and you are a very special person to the work that we all do in mental health in the community. And I don't know of anyone who's that dedicated, committed, show up or to make it work, you know. And so there's not anyone else in our community who does this kind of work. Okay. I shouldn't say anything more or you'll feel too proud of yourself, but
Well, it's kind of difficult to stand up here and have people say good things about you. Don't you know how it is? You got. Thank you, Tim.
I want to say one other thing for the county staff and so on. The county has this very nice connection relationship with the county and to the Department of Behavioral Health. And so we have our meetings in here, and we've have some meetings over what do you call that?
Humboldt Plaza.
Humboldt Plaza, and being staff and being NAMI and other things like that. We work together, and I want to say thank you to the county for that. Okay.
Okay, I just want to say a couple words.
Please do.
I won't be as very long, but first of all, I appreciate Tim's support of Humboldt County Mental Health, which started way back when Lance Morton 25 years ago offered me a position as extra help for families, because when my own son 25 years ago was diagnosed, I didn't even know where central virus was. I couldn't even figure out how to get in there. So I started volunteering, so ended up over the last years doing first volunteer, then extra help, then case management. And I appreciate the county mental health still knowing and realizing that families need this support. And they've supported NAMI and me through all of this. I just had a couple of crisis calls this morning, and my phone is on from 7 in the morning to 10 at night. And weekends, it doesn't matter. So guess what? I get a lot of prank calls. I have to pick them up because I don't know who's on the other end. So again, I thank the county I didn't know I would be drafted into this arena 25 years ago when my youngest son was diagnosed with bipolar disorder. It changed my life. I went from teaching special ed in Redway to being fully, involved up here. I've seen amazing things happen. I mean, it's hard still with involuntary treatment laws and other issues, homelessness, substance abuse, but our changes in our community are amazing. And I have people come here that say, wow, Humboldt County has a lot more than where I was. And we're getting more and more resources, more and more people involved. And I think it's just one person helping another person, or one person realizing mental illness is a biological chemical brain disorder. It's nobody's fault. These folks did not choose to be mentally ill or homeless or substance abused. It's just the way of the things happen. So again, I'm not going to take any more time from you guys, but I sure appreciate being here, seeing all of you, and I will be kind of walking out at 1:30, no offense, but I have to go down to Redway to do a support group down there. So anyway, you guys know my number, and anybody can call me, and what, how do they say, life is good. That's where these t-shirts on. How about some applause?
Okay, Tim, I'm gonna remain seated for this so I can read from here. But this nomination is for Eureka Police Department's Community Safety and Engagement Team, which is also called CSET. CSET was formed in 2018 to address problems in the community related to quality of life, addiction, and disorder in Old Town, the waterfront, city parks, and other public areas. The population that they work with is primarily homeless people and people who are on the street, addicted or mentally ill. This is about half of the team here today. The other half are off or working. But the team includes sworn officers, mental health clinicians, and community service workers. And they work proactively when they can with folks who have mental illness and addictions. But in any event, when they do engage with folks, they try to balance accountability and understanding of folks' condition. I don't know what Leah was saying, people are where they are. And I think CSET tries to meet them where they are and address the problematic behaviors, if that's what's going on, or lack of safety or health or whatever is going on with the folk. But they try to address them both with accountability and compassion. At the same time, they're trying to address some of the root causes of the behavior by hooking people up with services that are intended to address homelessness, substance use, mental illness, food, clothing, whatever it is that is an issue. They try to connect people to help. By having a dedicated team working with this population, same folks over and over again, they establish relationships and rapport and trust, which allows them to both convince people to accept and use services, but also to some extent to change some of the problematic behavior. The kind of the genesis of this kind of a response is, I think most everybody knows that Reagan emptied the psychiatric hospital, didn't empty them, but significant reduction in beds back in the 70s. I forget the percentages, we have less, but if you look at the additional beds of incarcerated people, it's comparable. And our population is growing. So those folks went from the hospitals into the streets. And obviously the law enforcement has to address the behavior of people that have issues with behavior on a regular basis. And I think what we've seen over the years with organizations, subdivisions like CSET, CIT is kind of an understanding that just strict law enforcement, you code outside the line, off you go. That wasn't working. And so, in my mind, it took a while for our society to kind of figure out what was going on and maybe what's the best way to deal with it. And that's things like CSET, where they're trying to meet people where they are. Just personal note, I did a ride along with Officer Clark about 2 or 3 months ago and kind of saw some of the things I'm describing, just pulling up, knowing people and whatever the problem was solving. The one thing, there was a lady who was sitting in the lobby at jail and she was there to report bugs in her room. And at first we all thought that maybe she meant some kind of, listening device. And turned out it was actual little bugs that run around. And Officer Clark took the lady, loaded her into her vehicle, went up there and kind of looked the place over and I think reassured her and did a little bit of getting in touch with the people who are running this motel. And so just things like that, are a little bit out of the normal lane of law enforcement, or at least at one point. So anyway, at this point, I'd like to thank the staff of CSET for all their hard work, and that's what this board does. And also the EPD leadership for their support in recognizing the need and providing the staffing for this kind of a unit. So with that, I would like, what don't you do?
I'm just gonna take a picture.
For those that don't know, Laura is also a CSET staff person. And
And you can be strong.
yeah, all the flowers I got for you guys are down in my truck. Who wants to come down? John, they buy some flowers. Right here.
We want a picture of me handing it to you. You should get in.
So before we do that, I'd like everybody to introduce themselves.
Oh, yeah.
Good afternoon, everyone. I'm Brian Stevens. I'm the Assistant Chief of the Erie Police Department.
I'm Leonard LaFrance. I'm the Commander over Investigation Special Teams, which includes CSET.
I'm John Omi. I'm the newest sergeant that's assigned to CSET.
And I'm Laura Montagna, the CSET.
And Behavioral Health Board Director. Not director.
Yes. I'm a CSET CSO person.
So let me then thank you. Let me formally hand this to you. I thought it had your name on it.
It's all right.
It doesn't.
A lot of people involved in it. A lot of people involved in it.
So we're gonna be photographic now, okay?
Photographic. Hey.
Hey.
Okay, and then wait, a classic. Thank you.
I think Laura, and I just think what you do is incredible. A lot of us do what we know about it. I'm glad that Laura has been here and to keep letting us know about what you're doing. It's special. It's really great. Our community. Yes.
You stand over there, Laura, and I'll just get it for a picture of all of you. And Tim, aren't you being?
Both Tims?
On both Tims, yeah. This, my hemming handy, the hairy bug. Yeah, well, geez, thank you.
So would anybody like to say anything about what you do and
Sure.
how you feel about it?
Sure. Yeah, the past 5 years, when we developed the team, we really didn't know where we were going to go with it. We brought in, besides just our mission for the actual law enforcement team, but bringing our outreach workers with Uplift, bringing our clinicians with our care team. So we have our mental health clinician now on staff with case managers, and we have a ton of partnerships with the county, with Providence, Katie and Calvin. I talk to them quite often. There's a ton of other partners, Betty Chin, Free Meal, The Mission, Salvation Army, with the warming centers we had partnerships with Lifehouse Church. There's a ton of partnerships we're working with. So even though often, we'll get credit for this. However, it's a much bigger, deep pool of roster that's supporting us, getting the mission forward and also supporting what we're doing in our approaches. So we appreciate it. Thank you so much.
Thank you, everybody. All right, time wise, we're doing just fine. This is the time for public comments, for you to share About 3 minutes with on your mind about mental health services. I do want to say something. This is also a public hearing for the MHSA a plan. And so what I want to also offer you is after it has been presented to us, it's time for anyone to make a comment. Your comment will be recorded and a part of this report. So having said that, other comments or any comments, from members of the public?
I can go. Can you all hear me clearly?
Yes.
Awesome, thank you. My name is Cerberus and my pronouns are he, him, his, and am, airs. And I'm coming to you today as a queer, trans, disabled youth in the community you claim to serve. I'm here today because I'm greatly concerned by the Draft 2 Mental Health Services Act 3-year plan. This document is riddled with disparities, and I'm frankly astounded that this is what's been presented to our community. To name just a few key issues, there is a severe lack of funding for LGBTQ plus direct services, or 2S/LGBTQIA plus services. Despite including data displaying gender diversity in our community, there's no list or usage of the words gender affirmation or gender affirming surgeries. Gender affirming care, my mistake. Within this document that claims to be a mental health plan, there's no use of the words autism, neurodivergency, and there's a severe lack of direct attention and funding to the care of people in this community living with disability. The approach in this draft is not meeting base standards of care, and I know I'm not the only individual or organization to provide labor in the form of this feedback. It is insulting to see the labor and needs of the 2S LGBTQIA community, Black and Indigenous people of color, and those living with disabilities in this community disregarded in this way. I urge you to listen to the community feedback that has been provided to you and to review this document in its next stages. Thank you
very much. Thank you. Other members of the public? All right, I'm gonna then move on. On item number 5, these are the action items. First is to approve the minutes.
I make a motion, we approve the minutes from the 4/27/23 meeting as submitted.
I am always can count on for that. Anybody else?
Second.
We have a second. Anything is on them that you want to add clerical errors, misspelling your name or something? And I think we're all ready to vote. All in favor, raise your hand. It's really close to the unanimous. Okay, so now the next item. Sorry, I'll slow down. I'm manic today. The slate of officers, let me just say about this. We did ask you before if you wanted to be an officer. The executive committee basically came up with 3 names. The executive committee is the chair, the co-chair, and then the second co-chair. And so the slate of officers we bring to you is the chair, Laura Montagna, and I've accepted to be the co-chair of the executive committee and of the board. And
You mean the first vice chair?
is that what it is?
First vice chair.
Thank you, write it correctly, Joe. First vice chair. And then Alyssa has agreed to serve again as the third vice chair.
Second vice chair.
So you're gonna be doing this, and I'll be backing you up, you understand this. I'm glad for everyone doing this. Other questions or comments? Anybody who wants to start their campaign at this time? So all in favor of this? Yes, sir.
Ask for any other nominations.
I thought I did. Are there any other nominations? Hearing no other nominations, all in favor of the slate, raise your hand. What?
You were supposed to ask if everyone was saying anything. And so what I'd like to say is I want to thank the 3 people that have agreed to do it. And I appreciate their doing it. And I also would recommend that anybody that might want to do it in the future, think about it in the intervening year or 2, and maybe be willing to step up and when they step down.
You can join the executive committee to figure out who we are and what we're doing if you'd like, as a member of the board. Can I ask for the vote now? All in favor, raise your hand. Okay, thank you all for those areas. So I think we have time to deal with item C, the approval of the letter from the Legislative Ad Hoc Committee, the Board of Supervisors. Tim, you want to present that?
Sure. So what
I'm
everybody should,
assuming everyone has theirs, right? It was mailed out.
yeah, everybody have, and there's copies up here if you don't. So about a month ago, a month and a half ago, we formed an ad hoc committee to look at all the different legislation that is offered up this year to the state legislature that has some connection to mental health and substance use. And I want to thank Nancy there, Sharon, I guess isn't, but for doing a great job of, they call through hundreds of bills every year to figure out the ones that might have effect on DHHS and its clients. And you not only pull all those out, but then they kind of went through and brought a number of them to us that we might be interested in, but might not with a higher priority. Out of that, we're using their advice on which bills had legs, which bills were likely to go anywhere during the year. We've developed a short list, and that's what you've got in the draft letter. The one bill that got left off of it is AB 43. We had a special meeting on that, and I'll talk about that in a minute. But in terms of approving the letter, you should consider AB 43, which is expansion of definition of grave disability to be another support letter or support item. So very briefly, the first one, AB 665, has the primary thing that it does. It allows minors to consent to voluntary outpatient and residential treatment without having to be deemed a danger to self and others or the victim of child abuse. And it's the same as other state law. It allows minors that are getting using Medi-Cal to have the same ability to do that other youth have that have private insurance. So we recommend support. The next one requires the Medi-Cal program to automatically approve a prescription refill for a drug for serious mental illness for 1 year, 365 days after the initial prescription is dispensed. And what that does, if anybody gets medications, they know that there's often delays and issues that stand, things that come up, one of which being refills that's keep people from getting their meds. And as you know, someone with mental health issues, sometimes any delay in having medication can be pretty dire consequences for them. So this makes it a little easier for a year so people kind of are in kind of a rhythm and groove in terms of getting their meds. SB 45 is establishment of acute care hospital loan fund to provide zero interest loans to counties to construct or renovate psychiatric health facilities. It's hard to get the money to do that, and this bill will help with that. It was vetoed last year due to funding. We'll see what happens this year if it passes. Funding is also an issue this year. AB 67 and SB 63 offer grants to counties to establish homeless or mental health courts. And we recommend support for that one because they've been effective ways of addressing issues like talked about with CSAT, where people are coloring outside the lines, and the homeless and mental health courts work with these folks in more of an informal way to try to address the behavior and the needs of these folks. And then finally, AB 43 is an expansion of grave disability. As you probably all know, that the 3 criteria for involuntary commitment for a mental health, for mental illness in the state of California are danger to self, danger to others, and grave disability. The current definition of grave disability is when person, well, for danger self or others, it's when it's, the problem's imminent, the danger is imminent. And grave disability, currently does not allow, for people that are seriously deteriorating, people who have both either mentally or physically. And what this does is tries to intercept these folks before it's a danger or they're seriously ill or dead. So anyway, that's the change in the definition. Our discussion included some discussion of what was, Vernon, you know what it was? It was the I'm drawing a blank on it, but maybe you'd like to, you had a difference of opinion on one thing. Maybe you like explain what that is.
I have a difference of opinion and I voted against supporting the bill in opposition. The reason why I'm in opposition to the bill is there is 3 civil rights violations that are potential if this bill passes. And second of all, and first and foremost, where are we going to put the individuals? We don't have space now, and we're sending people already out of the county. And then where are we? We're not prepared to pass this bill. We need to prepare ourselves first with building facilities. And that's pretty much it.
So thank you. So the one of the things I mentioned, the significant deterioration, debilitation, also with people that are unable to attend to their personal and their medical care, their self-protection and safety. And I want to give one example. I think I mentioned last month, but a fellow down in Vacaville, he's got a traumatic brain injury from a motorcycle accident that happened when he was young. He's got schizophrenia, paranoid, and he's blind. And he lives on the street. He's lived on the streets of Vacaville for 15 years. And he's on a regular basis. He's got family there, but he can't live with them. On a regular basis, they bring him food, they bring him clothing. But on a regular basis, he's robbed, he's beat up. He lives in 110-degree heat on the sidewalk. He lives in 40-degree weather in the winter. And blind, he walks through the streets. He walks in the street. He's been hit twice. Spent months and months in the hospital. Under the current state of California law, as interpreted by Vacaville, he is not gravely disabled. Well, I think I mentioned this, his sisters said every year when they hit winter, they wondered, is he going to make it through? And last winter he didn't. But anyway, so Vernon's got a point as far as, do we have beds? No, we don't have enough beds, even without changing the definition. But what I would suggest is that we should not define what grave disability is by whether we currently have the facilities. We should define it by reality. Is this person gravely disabled? Does he need our help? And if the answer is yes, then we should call a spade and say, yes, this is what grave disability is. It's a little more than what we've been calling it. And then we can address the challenge of providing mental health services, providing housing, whatever. That's my take on it. We need to define grave disability by what makes a person unable to take care of their personal needs and health.
Okay, thank you. Thank you to all of the for you and the committee. It's the time for open discussion. What I want to remind you is that we're voting on the letter itself, that at the bottom it says sincerely Tim Doty. And there are other important information. So those things, and, but I understand, Tim, you want to add in AB 43.
Yeah.
Onto the letter.
Yeah.
Okay, and so, and when the letter goes out, we will add AB 43. So let's have an open discussion about.
Is there a motion about adding AB 43 or do we need a motion?
We haven't made a motion yet.
We haven't had a motion call. It's just, people could add other bills, take some off or whatever. you want.
We don't have a motion yet. We're discussing it and, okay.
All right.
And I also want to say, you can pull something out if you really don't like it and have a discussion about that, because that's what we're here to do, is to approve this letter. We're not trying to just dump it all. So, discussion. Yes, Debbie, speak
I
up.
will say that NAMI California is strongly in support of this, is it AB 43, AB 43.
43.
And just from the perspective of many families, and we just heard this the other day at the support group, that people do language for lack of treatment. They all sort, we hear this in support groups from family members all the time, this frustration about how far it sometimes has to go before a person is seen as eligible under the law. There are examples in this community, and that was quite an example. But there are some examples that I won't go into right now, but because I think you read about them in the paper quite frequently. But so therefore, I mean, I would support your philosophy of the definition being changed and try to find the resources. And if the definition is changed, then you potentially have a way of lobbying for more resources too.
Jim, I'm not on the board, but just to piggyback, families are asked to starve their loved ones. They're asked to kick them out and make them homeless. They're asked to do all these things, which families, a lot of them won't do, refuse to do. I think it's important to support it, but one idea is to take AB 43 different letter and make recommendations and not put it on this letter. The other recommendation is, as Tim said, yeah, we don't have the care, we don't have the beds, but to pretend you're a flamingo and put your head in the sand when kids are dying every day or in jail forever because they've been psychotic and committed a crime. So I just wanted to piggyback on that.
Thank you. Yes.
Tim, I have a question. Is there the legislative language address the differences in describing a person who is severely disabled versus the current status of description? Have we seen any language within that legislation?
Yeah, I think, yes, I've seen it. I think, Nancy, did you distribute the actual language for the bill?
Tim, I did not. That wasn't part of this agenda item. So we're kind of pulling something off of the update and putting it onto the letter. So I mean, we can have a detailed discussion about SB 43 now, or you can agendize it later. But I will just note that it's probably the most controversial bill in the state legislature this year. So I'm happy to pull up information and start going through the details of the bill now, if that's the will of this board, or you can agendize it separately and we can go through the bill language as the full board. I'm looking for process direction.
I appreciate that.
So to answer your question, Colleen, is you can Google it. Really, I did it this morning and looked at it. And I read the part that's most pertinent to the difference. And, that's being intercepting people before it's imminent and, adding the whole thing, if somebody's sitting on the street and they've got a festering gangrenous wound, that they can be, if it's because of their mental illness, they can be on hold for that, because they're not attending to it, among other things. But yeah.
Does that help pull in?
Yeah, thanks.
Hey, Steve, I saw your hand.
Yeah, I was wondering why it's controversial. Is it for the reasons that Vernon suggested, that if we identify this and we don't have a place to take them, that's a problem? I mean, I appreciate what you had to say, Vernon, I really do. But when I think about it from our perspective as a board, I only represent myself here, although I'm appointed by the board to be here to represent the whole board, but I want to be careful about, as you might have seen recently. At any rate, if we don't identify this, it lowers the numbers, right? And then we could say, well, there's not that many people we need to take care of, right? So I mean, on some levels, it seems to me if people need help, we ought to identify it. And then that adds weight to trying to figure out how to come up with resources to help. We don't have them now, we know that. But it adds weight to maybe not just rehabbing Sempervirens, but building a new facility with 50 beds and 12 juvenile beds and things like that, which as a board, we're looking at our facilities master plan and trying to figure these things out. So I totally understand what you're saying, Vernon, but I do think it's probably important to identify populations that need more help, because then that's what feeds the system to say, let's get the facilities, let's make it happen. It's just a thought. But thank you, Vernon, for your input.
I would just want to add to Vernon, largely the opposition is around civil rights groups. So the ACLU, disability rights, mostly peer organizations are on the opposition side. So it really, just to be clear, it really expands the definition of gravely disabled for purposes of both LPS holds, so 5150s, and for conservatorships. So it's certainly, yes, about the lack of resources for public guardian and for county mental health. But this would allow conservatorships for people with straight substance use disorders in addition to co-occurring. There's also opposition from LGBTQ rights groups and the Black Health Network around just equity issues and the historically marginalized people and coercive treatment. So this is, I'm just saying this to say that this is it's a complex bill, it's a controversial bill, and I'm happy to answer more questions if your board wants to take action on it today.
I'm going to go with some comments, questions, Vernon, and then Debbie, and then Debbie.
I would like to ask Ms. Stark, is it the California State Behavioral Health Board directors that is also in opposition of this?
That's right. The County Behavioral Health Directors Association, CBHDA, which represents county behavioral health, does have a number of concerns, including the equity concerns I just mentioned, and of course, funding, and there is no state funding involved in the public guardian's office.
Thank you, Debbie, and then Emmy.
I was going to ask the status of this bill. It is controversial, but it's also very popular, is my understanding. And I think the legislature, maybe Nancy, you know the answer to this, but it has been voted on in one form, or it's at a certain stage where
Nancy knows better. It's moving, the governor's in support of it.
yeah, I think in terms of representing the public, the state representatives, and I'm sorry I don't know the details, but I do think it's fairly popular in the legislature. People are in favor of it who are representing the public.
So Nancy, maybe you can clarify us on the process of something being voted on and approved as a bill, and where AB 43 is in that list.
It has passed each of the committees, and I believe the full Senate with no votes. so far. From here, it goes over to the Assembly. I believe it'll start at the Assembly Health Committee, the Assembly Judiciary Committee, Assembly Appropriations Committee, and the Assembly floor before it would go to the governor. And yes, the governor has offered verbal support for the bill.
And what's the timeline on that? When do you expect it to be on the governor's desk?
Well, it would have to be to the governor's desk in September. And then he'll have 30 days to sign or veto it.
Okay, thank you. Emily would like to add something to that.
I just, to the question about the controversy and what it is that's being lifted up, and yes, CBHDA has lifted some of the concerns. It's not an issue of not wanting to help people in need or those who are suffering. That is not the issue. It's an issue of certainly of resources and allocated funding that would support providing services to this population. It's an issue of that I'm hearing, understanding. It's an issue of disparity in some certain ethnic and racial groups. There is civil rights at hand, and also there's question around the effectiveness of forced treatment in some circumstances. So for somebody with a substance use disorder issue only to force treatment, the research shows that that does not have good outcome. And in fact, in some situations has very adverse outcome. There's some studies that show more people actually die in those situations than in it's presenting similarly who end up in jail. And so, you know, I don't say that to sway your board one way or the other. This is certainly your decision, but just kind of to speak to some of what the controversy is. There are some concerns about the impact and whether or not what's being sought by this bill will really have the outcome of what's intended, that really to help people in the ways that are most effective.
Thank you, Emily. Yes, Alyssa.
Emmy, you laid out in the different ways, the concerns that have been brought up about it. Personally, do you feel like this bill will help people in the way that it's intended to help people?
Well, I mean, I think the things that I voiced are genuine concerns, and we wouldn't know until it actually rolled out the effect of it. But I do think that we are tasked with providing services without enough resources already. And I would have concern about forced treatment in situations where it's not proven to be effective. So I would have concerns about that as well. We in Humboldt County happen to have one of the highest rates of conservatorship throughout the state. And so we already are very under-resourced and challenged to provide those services locally. So it does mean kind of out of county referrals or placement, and which, you know, has challenges in that you're taking people out of their comfortable local supportive environment to get treatment. So, and, you know, like I said, there's no intention not to help the people who need it. To my mind, I just want to find the pathway that's going to be most effective and that's really sustainable financially for our community.
And not harm people.
And that causes no harm. Like that's what we're tasked with, right? Not to cause any harm.
That's awesome. Thank you, Emmy.
Any other comments or questions?
I'll just throw another local example, and we had a young man who was very ill, extremely ill. He had starting little fires in his room. He was defecating in his bedroom, drawing on the walls. He was paranoid, and he was found not to meet the criteria to be in a hole, not gravely disabled, not a danger to himself or others. And not to underplay the difficulty in some cases, especially with violence, of predicting. But the grave disability aspect, someone is defecating in the room, and that individual 2 days after not being put on a hold came out of the room and stabbed his brother in the heart, and he died. And that wouldn't have happened had he been put on a hold. And is that coercive? Maybe it is. But he needed, for his own life, he is now incarcerated. He's in a state hospital, and he's going to have to live the rest of his life with having stabbed his friend, his best friend's brother, to death. I don't, to me, it's like a person that has sight issues, who's walking for a cliff and not stopping them, grabbing their arm and bringing them back and saying, hey, you're heading toward danger. And anyway, I said the other reasons that Steve reiterated. We need to call a spade and say these people are disabled and figure out how to fund additional people for the public guardian's office or whatever the case.
I have a clarification. I'll give you a clarification, Steve. What happens when a letter like this is given to the clerk and presented to the board of supervisors? What is the process of that?
We would ask Emmy to come forward and Connie and give us their input, which Emmy just gave us very eloquent, input in regards to. These are really difficult things. Yeah, we all immediately want to help. We don't want to harm, and yet how are we going to do that? And there is no easy answer here, but that's how it works. We would talk to our experts here on staff and ask them their opinions and feelings. I mean, that's what happened with the AOD, is it? AOT. That's exactly how that worked. And staff were very concerned about our county's ability to respond to that, because budgets are already, and so basically they had to take something away from somewhere else in order to do that, because we didn't give them new money to do that necessarily, right, Emmy? I mean, it was just, go ahead and do it. Let's figure it out. I mean, to a large degree. So that's how it works. And then we try to make that tough decision, right? And in that case, we chose to move forward. And the staff have been doing an excellent job of trying to make that work, but there are no easy solutions, although I will say that if our rates are higher than anywhere else, you would think that we could use that to leverage resources.
Yeah.
And I wish that was just so perfectly connected, but it's not. I mean, it amazes me how we can have such high rates of this, that, and everything else, and yet I don't see more resources coming because of it, especially now that the budgets are going to, so it's complicated stuff. And I would say that you're not going to have the resources, but you are infringing on people's rights. That's really kind of a tricky area, right? So there's valid points on both sides, and that's why this is such a tough issue.
I'm ready to move ahead, whatever you want to do, but let me get Alyssa and then you and then Laura.
So from what I'm hearing in the behavioral health board legislative meetings that we did and here and everything like that, I'm hearing that gravely disabled needs to be looked at. The definition of gravely disabled needs to be worked on, but this might not be the way to do it.
Okay, thank you, Oscar.
So back to acknowledging AOT as a new entity in our community and having them work with 10 people at a time. We all know that this is, and for those who don't know, this is a result of Laura's law that was passed. And what I want to say to this is that people who are at such severe level of their mental health and it's been undiagnosed and untreated for so long, it's really hard for them to be able to adhere to their own medical advice or to the medical advice of their primary care physician or of their immediate friends or families. And what this allows people to do, not immediately working with those people, is clear up resources, the limited resources that Humboldt County has, to other people who are willing to adhere to that medical advice, to get into the court system, to get into a treatment center. And so the people who are in AOT, there are individuals who are constantly cycling in and out, right? Taking resources, taking funding that is scarce to our community, right? So we have to acknowledge that, yeah, we're trying to build more. We're trying to develop, more outlets, but currently we have limited outlets. So we don't support additional AOT programs within Humboldt County. I could see one in Valley West in North Arcata. I could see one in Blue Lake. I could see multiple in Eureka, right? But my comment and my intention to share with you all is to acknowledge that, yes, sometimes forced treatment is not deemed favorable to that individual, but we have to allow our AOT services to grow, develop, and manifest a good outcome for those limited 10 patients so that we can learn and create that as a model and scale it appropriately to reach targeted individuals that would do well with that.
Thank you. We are running out of time. And because the MHSA is a public meeting and we need to give it time to do that. There'll probably be a lot of discussions about that. So whatever the board wants to do.
I would like to just make a motion that we approve the letter that was submitted before the AB 43. We send that to the Board of Supervisors and then we put on the agenda further discussion for AB 43.
That's a motion we have. In fact, it's the only motion we have right now. Alyssa,
Second time over.
this is an amendment issue. You ready to vote on this?
Yeah.
All in favor of?
No, I'd like to say something.
Okay.
To address what Alyssa said about the, that we need to change the definition of grave disability. Is that accurately?
What I'm hearing is that we may need to look on expanding or changing the definition of grave disability, but this bill may not be that.
But that is exactly what this bill does.
But it expands services to people who, like Emmy said, have been shown to not be positive outcomes from that sort of treatment style.
I'm gonna interfere here because that's the reason we can go talk this more and we are running out of time. I need to give 1 hour for the Mental Health Services Act. Okay? No, you don't like it? Okay. So we have a motion for the amendment. All in favor, say aye. I know we're talking about dropping AB 43, right?
Just for now.
Just for now, yeah, we're gonna revisit it again, but this letter that we're sending out, we're talking about. So I see a majority, am I right on that? Anybody else? You unsure?
I'm abstaining.
You can do a roll call.
Okay, let me see, if we don't have a quorum, we can't do it, so who's in favor of putting this to AB 43 elects? I see 1, 2, 3, 4, 5.
What is your question?
Is how many people are voting for the motion?
The motion is.
I am asking for people to declare, let us know whether they vote for putting AB 43 for next time or not. And so there's a lot of indecision. And so
You're asking if they can go to move the letter forward and to revisit.
that's what I'm asking, to move the letter and then look at AB 43 the next meeting. All in favor on that motion? I don't, 1, 2, 3, 4, 5, is that?
I need 6 since we have 10 members.
Okay,
Is some people are abstaining, doesn't that change the number of votes that are required?
I don't think so.
No, okay.
It's like a non-positive vote. So the motion fails at this time. We'll pick it up later. I know this is tough stuff.
I'd like to make a motion that we approve the letter with AB 43.
Okay, all the people who want to approve the letter with AB 43. Oh, we need a second for this.
Was there a second?
I made a motion. If somebody wants to make a second.
To include. Okay. I think we've had enough discussion. All in favor of approving this letter to go to the Board of Supervisors with the inclusion of AB 43, please raise your hand. 1, 2, 3, 4. The motion fails. Or did I? 1, 2, 3, 4, 5. Oh. Am I not missing something?
Colleen, 1, 2, 3, 4, 5. You know, there's just 5.
Yeah, there's just 5, so the motion fails.
And I would just say I abstain on any letters that we're sending to the board.
You'll get them anyway.
All right, let's go ahead with the MHSA public hearing. We may have hardly any time for anything else, so I want to give you the time. Can we get started here? Yes, it's yours. Perfect.
Deep breaths.
Thank you, everybody, for being here today, and I appreciate the board for hosting this meeting.
My name is Oliver Gonzalez. I'm program manager for the Mental Health Services Act. And all the information I'll be going over is regarding our 3-year plan, our draft 3-year plan for 2023 through 2026, with an emphasis on the community program planning process. I don't think my clicker is working. Hey,
Joe, can you make sure his clicker's working?
Yeah. Can you just hit the right arrow then, if that's the case? On the keyboard, to just switch to the next slide. Is the right keyboard? I think someone underneath.
This is underneath.
Yeah.
That's the one that we need to.
Really hit it up there.
Who is that?
Maybe if I move to the front. There we go.
There we go.
Oh, did you get it?
Got it.
Oh, got it. Thanks, Laura.
You're welcome.
So then I'm just gonna say, Joe, if you're okay with it, I'm just gonna say next slide.
I'm sorry, I'm hearing separate conversations going on. And I need those to stop so that everybody can listen to the report. Gardner?
So with this presentation, I have 3 objectives. Objective number 1 is to give you a brief history of the MHSA and all the components that we have under our draft 3-year plan with a breakdown of all those programs. I'm not going to go in depth as to what each program does because I'm assuming you had a chance to review the 3-year plan in its entirety. Objective number 2, I'm going to give you a breakdown of the data I collected throughout my stakeholder meetings that were hosted, and also a breakdown of the data of the community survey that we had available for the public to be an active voice of our plan. I'll also be giving you a breakdown in there of the biggest themes that we encountered with all this feedback. And then lastly, objective 3 would be listening to community comments, questions, and input. So then we'll go to the next slide.
Yeah, we got it, Joe.
Oh, excellent. So. Okay, sorry. Okay, so with comments in mind, we actually have a demographic form. Those who are attending here in person, we got a physical copy, I hope, that was up here. It's a voluntary and anonymous demographic form with the goal of just documenting just overall how well we did in terms of including people. The end of the form also has a portion for comments as well. So if you have a comment that you didn't get a chance to share, or maybe you wanted to ponder a little bit more about it during this meeting, there's your opportunity to also give me that comment as well. For folks that are joining via Zoom, my colleague Alex Oliveira is actually going to be dropping a link to an electronic version of that form as well. Also, I just wanted to highlight that all different email address that we have available too, which my colleague Alex will drop in the chat. This is mhfacomments@co.humboldt.ca.us. And this is an email address you can utilize as well to email me anything that you might have in mind after the fact. And we're gonna be taking comments until the end of the day today. So that's another mechanism. And also we're taking notes too of each individual comment, question, or concern that is raised in our meeting as well. So with all of that in mind, I'll give you a brief history of the Mental Health Services Act. The Mental Health Services Act is a income source, essentially, that was created through Proposition 63 in 2004 and enacted into law 2005. It put a 1% income tax on millionaires, essentially, with the idea of funding equitable services for behavioral health branches, specifically services that oftentimes either get missed or where populations are not equally represented in our communities. As you can see in this chart that I have here, we have this kind of how like the money trail works. So first of all, we have the 1% income tax that takes place. It gets all collected into the California State Treasury, and then it gets broken down into 2 separate sections. We have the larger bubble, which is the 5%, And that 5% gets broken down to state agencies such as the Department of Healthcare Services, the California Behavioral Health Planning Council. We also have the Department of Healthcare Service Access and Information. We have the Mental Health Services and Oversight and Accountability Commission. And we also have the Department of Public Health to get MHSA funding from that 5%. The other remaining 95% gets distributed to all 58 counties, and they use a formula that takes into account population density to determine how much money each county receives. So since we're in the conversation of money, and I do understand it's a little bit blocked right here, so I do apologize. This is the estimated funding amount that we are currently having in our 3-year plan. This is the whole dollar figure for all 3 years. So we're about $39,318,053. Okay. I also have a breakdown with that pie chart as to where each component is getting these funds. So as an example, that large blue component that you see there, that's 71% roughly, and that's our community services and support. That's then followed up by the gray bigger spot, which is about 22%, and that's our PEI, our prevention and early intervention component. Coming in third is 8%, which is our innovation component. And then lastly, we have our workforce education and training component, equating less than 1%. Oh, and I also want to emphasize to those percentages that I'm mentioning and the way it's broken down, that's not random. We're actually mandated by the state regulation to distribute our funds in this capacity. Just wanted to kind of point that out. So up next, I'll give you just a really brief breakdown of each component and what program is under that component. So under the community services and support, CSS, these are programs that serve underserved and underserved populations with an emphasis in eliminating disparity in access and improving mental health outcomes, improving mental and other unserved and underserved populations. So in here, we have our 4 programs such as comprehensive community treatment, which we also call full service partnership. We have our regional services. We have older adults and dependent adults. And then lastly, we have the crisis residential treatment. Then we have our prevention and early intervention component, PEI. Now, this is meant to, it supports the design of programs to prevent mental illness from becoming severe and disabling. And this is the list of programs that we currently have funded through MHSA. And I say that because also at the end of that bullet, you see new initiatives, which are right here. These new initiatives are not funded currently under MHSA. They're not active. However, we have a budgetary breakdown in our 3-year plan that gives you a breakdown of exactly what we're aiming to spend on each one of these programs. I also want to give a special shout out to these programs because they're new, and on top of that, they're based on community input, right? So the Latinx liaison position, as an example, that's a behavioral health position we're aiming to create and fill, so that way we have a better penetration rate with Spanish-speaking populations and being able to offer better linkage to services. The Early Childhood Treatment Certification is a certification program specifically designed for mental health providers to get a better knowledge and a certification for our youth populations who are facing crisis. The Warm Line is supposed to be a non-emergency access line that's going to be available regardless of insurance type, and it's meant to serve as early access to linkage to services before they become severe or disabling. The next one is the Suicide Prevention Behavioral Health Quality Improvement Initiative. This one is meant to be an internal consultation for our behavioral health branch to help optimize our internal processes and also to help improve implementation of future service designs. And then lastly, we have a PEI assigned fund, Help Makes the Statewide PEI Initiative. And this is a very integral piece because ultimately it will help us maximize the capability of our PEI programs to be able to do outreach to our communities and just overall just expand knowledge of what is available out there. Okay, up next, we have our innovation component. Now, innovation is meant to develop and implement promising practices designed to increase access to services by underserved groups, increase the quality of those services, improve outcomes, and to promote interagency collaboration. We only have one innovation project as of date, and that is the Resident Engagement and Support Team, also known as REST. And you may notice I actually included some synopsis as to the specifics of this program, and that's because it's a fairly new program that just started in a limited capacity late last year. So I just wanted to share that with you, that information. And lastly, we have workforce education and training, which provides staff development opportunities to promote wellness, recovery, resilience, and culturally competent service delivery. Under WET, we actually have a Superior Regional Partnership Program, which provides opportunities to increase and retain our behavioral workforce. These opportunities are seen through financial initiatives such as the Peer Scholarship Program, the Loan Repayment Program, and the Graduate Stipend Program. One thing that I also didn't mention in this slide is it helps pay for our Relias e-learning system, which provides a systemic tool for our employees when it comes to expanding trainings. So with all of that funding in mind and all of those programs, right, we have to follow a lot of requirements. But the most basic county requirements are we need to complete a 3-year plan every 3 years. Okay, since 2020, we had a 3-year plan and now we're overdue for one, hence why we're planning this one. We also need to do 2 annual updates in between years as well. And that's to make sure that our plans are up to date. And as mentioned, this is for the 3-year plan, 2023-2026. And on top of that, we also require a community program planning process, which is set forth in California Section Code 3300. Now the community program planning process is essentially, it dictates how we should be conducting stakeholder meetings. It dictates that we need to be inclusive to population, pretty much a broader lens of populations. In Humboldt County, for an example, we have 5 regions, right? So I hosted 23 meetings as an example to all 5 regions to ensure that I was being as inclusive as possible, right? So again, anybody can be a stakeholder as long as you're a community member or whatever, you can definitely be part of this process. Everybody's welcome. So regarding the CPP, now we're getting into the data section of things. So we hosted 23 stakeholder meetings with 100, I know it's kind of cut off in our presentation, but with 191 participants in total. Those are people who attended our stakeholder meetings in person or virtually. Out of that, 69 participants, which is roughly 44%, completed demographic. On top of that, we also had a community survey running in the background. We had 229 responses through this community survey, with 85% of respondents mentioning it was their first time providing input through the community program planning process. So this is actually, this pie chart right here, I know the title's cut off, but it gives you a breakdown of the stakeholder region of residents. And again, this is for the stakeholders that attended in person or via Zoom. As you can tell through this chart, we have the 38% of people from the Eureka area, 35% from Northern Humboldt, and then 12% Southern, 7% from Eastern, another 7% from the Eagle River Valley, and then 1% unknown, as somebody who did not feel comfortable sharing their region with us. Up next, we have a chart on race and ethnicity of those that did attend our stakeholder process. And that is, we have here 1% African American or Black. We have under orange, we have 12% Hispanic or Latino. We have 7% American Indian or Native American, 4% multiracial, another 3% in Asian, and 73% white. And this chart right here gives you a comparison, a census comparison of how we did in terms of meeting with this demographics compared to the overall population of Humboldt County. Okay, for the most part, I feel like we did a pretty good job, but I also want to emphasize too, this is given that only 69 people gave a demographic survey response to us. It doesn't account the other 100+ people that did not fill out their survey. So I just wanted to kind of share that with you. Then up next, we have stakeholder gender. So we have 70% who report as a female, 23% as male, 3% non-binary, 3% as transgender, and 1% as unknown because they didn't want to share their information. And then the next one is regarding stakeholder age. So we have 6% that report being 16 to 25, 81% that was between 26 and 59, and 13% reported being 60 plus. So as far as stakeholders with lived experience, this is what this chart is depicting here. 29% report to be diagnosed with a severe mental illness. 61% report being a family member of somebody with an SMI, and 87% report being a friend of somebody with an SMI. So we got really good representation from the sample set regarding lived experience. And this chart right here is the percentage of stakeholders who identified as a member of the special population. So we have 25% under LGBTQ, 36% claim to have experience with homelessness, 35% with the justice system, 22% with child welfare, 4% reported to having a primary language not being English, and 3% reported with as a military veteran. So this next slide is about agencies and groups, people and stakeholders who attend our meetings identified with. Unfortunately, I know it's kind of cut up here, but top bar there, that's 25%, and that's 25% of people who didn't respond to that question, unfortunately. But then following up, we have 19% under education, 17% under mental health services, 2% under community family resource center, and then the list just goes on. Okay, so I understand that this table is really hard to see from our angle, right? So we took note of every single stakeholder comment that was made in person or just in through Zoom. And we made a theme followed by a tally of number of times it was mentioned. The top 3 that were mentioned were bilingual and culturally responsive services, followed by expanding or increasing access to services, and the third being increase to support for youth. Now,
I'm sorry, you back up.
Yeah, of course.
So I can see more of those.
Yeah, go for it. And
What was the third group that you mentioned?
yeah, increase to support for youth.
Okay.
Yeah. And I do want to say to you, all of you will be getting a copy of these slides by the end of this presentation.
All right, thank you.
Yeah, of course. So up next, we're going to be transitioning to data that is specific to the community survey. Okay. So as far as the community survey goes, again, I know it's a little cut out by our bubble here, but we had 106 people that attended, like people that were from Eureka, 71 people from Northern Humboldt, 16 people from the Hill River Valley, 14 did not answer, 14 from Eastern Humboldt, and 7 in Southern Humboldt. And that is again respondents to our community survey.
Do you match it with the population?
That one specifically, we did not match with our population, unfortunately. But I can definitely take that as input for moving forward when we do that.
Yeah, or though not Eel River, what the percentage and then matching it, you know what?
Yeah, absolutely. Yeah, that's a really good idea. Okay, so then respondents, race and ethnicity. So we had 156 people that presented as Caucasian or white. We had 19 Hispanic or Latino individuals who responded to the survey. 17 people did not answer. And then 13 people were more than one race or ethnicity. And again, then we have 11 people who reported being American Indian or Alaskan Native. Right, and then the list kind of goes on after that too. As far as respondent age goes, we had 71% of people who were between the ages of 26 and 59. 16 to 25 was 7%. 19% was 16 to 74. And in yellow, under the 2%, we had people who were 75 plus. And then a couple of people did prefer not to answer as well. And then we have here respondent gender. So 3% responded with being another gender identity, 64 female, 8% as gender queer, yellow, 14% was male. So 7% prefer not to answer. And then on the green here, we have 4% who report as transgender. So, you know, one question that I added to our community survey that I was just really curious about was, in general, how are people familiar with our MHSA programs? right? Like how does that look like? And the numbers were pretty good, actually. So under TAY, which was on the top of the list here, we had 141 people that responded as being familiar in some capacity with our PAY service. Then suicide prevention falls at 133, regional services, then adult residential treatment, and then the list kind of goes on, right? So, and it makes sense for local implementations to be kind of in the bottom of the list anyways, because it's not necessarily a program specifically for service design, it's to fund organizations to provide a service design. So I just wanted to point that one out. Okay, so this slide is populations not adequately served by current MHSA programs. Now, this slide specifically. Okay, so this slide specifically has on the top of the list those with an SMI, and that number was 91 responses claiming that. Then followed with that, we have those at risk of mental illness with 90 people, homeless 84, other minority groups, aside from the ones we were already taking into account, 81, and then Native Americans with 72, and then the list going on. One thing that I really want to emphasize here is that this chart doesn't necessarily mean that our MHSA programs are not working. It just highlights a capacity problem, right? And that's something that our rest of our data actually really emphasizes here, where people are just in need of more services and we're not able to build capacity. So I just really felt the need of highlighting that aspect. So in terms of suggestions for programs or services, 44% of, or 44 people actually mentioned that the need for expanding or increased access to those services. 22 people.
So what does access mean?
Yeah, access would, in this context, would mean their ability to not just understand that the service is available, but also the process behind them getting that service as well. Yeah, no problem. So then, and then we have 22 people who responded the need for addition for LGBTQI plus services, and then we also put / culturally responsive services as well. And again, the keyword is responsive. Then we had 18 people who said workforce expansion and training and support. Then we had 16 people for housing services, such for those experiencing homelessness. And again, the list just kind of keeps going on in terms of the breakdown. So that's really the main data. Now I want to take the chance to really elaborate on some of these bigger themes that we kind of just saw. One of the biggest themes was the increase and expand mental health services, right? That would be in general to more communities in Humboldt County. Also to have more doctors, counselors, and other mental health professionals, having more mental health programs and provide the services and supports to everyone who needs them. Again, those were like the more common comments that we've seen from people. As far as LGBTQ and culturally responsive services, we saw increase in the availability of services with Eastern Humboldt, but honestly, it'd be also Southern and Eagle River Valley areas as well. That are more responsive to cultural needs. Create a mental health programs that are responsive to Humboldt's LGBTQ plus community. Increase inclusivity of services for the Hmong and Hispanic / Latino populations, and increase support for older adults. So, as far as workforce support, a lot of it was tailored on recruiting, retaining, and training our workforce. Mental health workforce and others who may encounter people needing mental health services, such as law enforcement, childcare providers, and teachers. And then we also saw housing and services for those experiencing homelessness. That would be more supportive housing, more supportive services for those who are not housed. Increased funding for emergency housing in areas that could use the additional support, and work with rental companies to overcome barriers for achieving housing. Then we had another theme that was one of the bigger ones, and that was continuity of care. And that's for clients released from Semper Virus, crisis stabilization unit, jail, or other transitional programs. Provide discharge plans, provide warm handoffs, and also transitional housing / placement. Okay. Then we also have an increased support for the youth. And that can be seen in the increase for youth for both pay and those not yet who are qualified or classified as pay. Support for first break psychoses, crisis support, and strengthening the continuity of care for families. And lastly, we have an increased support for those who are severely mentally ill. For those without anesthesia, more assertive care treatments, expand comprehensive community treatment, CCT, which is our FSP program. More case managers and other paraprofessionals. And I think also that's a better integration of counseling as well within some of our programs. Occupational support, such as supportive employment and shelter work. So with that in mind, and those themes that we have in mind, there's a couple of steps that are left in the MHSA marathon. One of those is making sure that I'm gathering all the input in today's meeting, integrating them into our 3-year plan portion of the public hearing report, providing it to leadership so that way they can consider any additional changes to our 3-year plan. And then once all of that's reviewed and we're good to rock and roll, going to BOS for approval and then submitting it to DHCS and the Mental Health Services Oversight and Accountability Commission. Now, I know like in the last stakeholder meeting, I kind of showed you all this graph. And I don't know, I feel like this graph I have is a little sentimental for me right now because this process started here with the BHP. It really did. The BHP the Behavioral Health Board was the very first stakeholder group. And I really appreciate the opportunity that you guys have given me in terms of being the host for the public hearing. I want to give a special shout out to Emmy and to the deputies and to all my other coworkers who have been really patient with me. I know I just entered this role 8 months ago, so I appreciate everybody's knowledge, guidance, mentorship, and patience. With that in mind, let's get some public comments. Thank you.
Comments, questions?
This is our opportunity to.
Yeah, I want to make sure the rest of the public can be, so if we can change that. The other people. Go, Alyssa.
So this is our opportunity to input our ideas into the next 3-year MHSA plan.
Right.
And this is the time to say something if we need to say it and to have something included in MHSA.
Absolutely.
Okay.
Questions and comments? Yes, Oscar.
Comment. And first, thank you so much. I'm really impressed with the thoroughness of your report and your attempts to reach out to a lot of people. I know it's really hard to get people to actually go onto things. So one of the things that I've noticed in the coming months, like literally last 3 months after I had a Transpo party, because I'm also on the board of CRTP, which stands for Coalition for Responsible Transportation Priorities. What I understood after a couple conversations with some people who work within like HCOG in the transportation sector was a lot of the times are the people that we support, they realize that they're starting to have worsening conditions and they fear going to their doctor to get them diagnosed because it means they'll lose their livelihood, meaning they'll lose their license. And in Humboldt County, your own independent transportation is everything. So one of the things I'm starting to acknowledge is, well, why can't we make public transportation better and more accessible to people with behavioral health needs? Right, that's one of the things that I'm noticing, like if there was an incentive and there was like some support there, that could be a game changer. So one of the things I would like to add to this, to this report would be the inclusion of transportation alternatives, transportation services. And I gave it that framing because it was kind of like I need to start an ad hoc committee. I need to start to voice this reason. Do other people agree? Where do they disagree? And how can we find some solutions? In addition to getting them have more access, we also need more drivers within Humboldt County. And people who are further along in their steps of recovery, they may be able to get secured employment as a driver to help fill that gap in addition. And so this to me lines within the innovation section that you've laid out, like the 8%, right, for innovation. This could be an innovative idea that could help create some more of that network. So that was one of my comments that I wanted to share with you all. And thank you for listening. The second comment I had was, you know, in terms of engaging the Latinx community, did you, this is the question, did you reach out to like Spanish serving agencies to help get that into the demographic? And if you did, which agencies and groups or organizations did you talk to?
Yeah, great question. I haven't fully engaged with a lot of organizations. I know that Promotores is one of our stakeholder groups as an example.
Well, that's a big network of us.
It's a big network for sure. They received the presentation as well too, as to the Latinx liaison decision. I do have scheduled to interact with other Spanish speaking communities as well later this year, actually, to do some tabling events regarding MHSA, and that way we can start kind of seeing what the perception is for these populations as well.
Wonderful. And if you ever want to reach out to me personally on doing some of that outreach, I would very much like to be a supportive agent in that.
Hey, Russell.
Thank you, Oscar. Comments and questions? Oh, I'm just checking with the people on the Zoom screen. There's usually a hand icon. I don't see them. Back to the people who are present.
Oh, there's one.
Okay, Cerebus.
Hi, I appreciated the data that was shared showing that LGBTQ plus populations are in severe need from these programs and are also being severely underserved. But that continues to fuel my confusion as to why LGBTQ is only used within the document to say that there will be more gender options and sexuality options offered in a specific form. There's no direct funding or services in this document that is directly for the 2S LGBTQIA plus community that I'm seeing. And so I'm confused as to how we're using this data that is time and time again showing disparity for this community. And yet I'm not seeing any as a person of the community, and I'm not seeing any within the document itself. And that's like where a lot of my confusion is popping up on this. I also would like to point out that the survey that you shared in the gender identity options, the options are male, female, transgender, and other. I don't know where to put myself in that category as someone who is male, non-binary, trans, and who has a lived experience that encompasses all of those marginalizations. And I don't find it appropriate to list the genders as male, female, and transgender as if they are separate categories. Those were my current comments. I don't have anything else at this moment. Thank you so much.
Thank you. Thank you. Other questions or comments?
I have a follow-up to that.
Okay.
Can you guys address the last comment? Like, Tay, for example, to what extent they're doing what is being asked for there without it being mentioned on the, in the document, but they're already doing that stuff.
Yeah, and I know, Sonia, I know you're here on the call. Will you be able to answer a little bit more about the take component as far as LGBTQI work that's being done today?
Yeah, absolutely. Again, Sonia, I supervise HCTC, use she, her. We currently have our round of policy recommendations on LGBTQIA and 2S youth across systems. We currently have a working group that meets twice a month for that, open to anyone in the community. We serve 16 to 26-year-olds on our youth advocacy board, and we do a lot of work with LGBTQIA 2S community. So we currently have a policy recommendations out, and we're currently working on them.
Thank you for sharing that, Sonia.
I'm fairly familiar with the work that Tay does, but that's still not a direct LGBTQ focus. That's someone who's doing wonderful work, and I would love for that work to continue. But supporting an organization or a movement that does this work is not the same as direct funding and support towards organization, causes, and people, and like that are by and for queer people in this county. Like that's what I'm looking for, is work by and for queer people in this county with direct mention to them, direct organizations, Redwood Pride, Queer Humboldt. We have so many lovely Lost Coast. We have so many lovely organizations here and so many lovely movements that I'm not seeing get the attention, funding, or recognition or support that they deserve to support communities by and for queer people. And while I admire all of the work done by Tay and HTCC and all of these lovely organizations who I absolutely want to get more funding for, I'm still not seeing what I'm asking for and what my community is asking for. That's my point.
Absolutely, and thank you for sharing that point, and we make sure to make note of it as well. We appreciate that. One thing I wanted to say too, that's not reflected specifically under this 3-year plan, because it just happened literally last week, is one of the local implementation applications that we actually ended up funding is for Humboldt, actually. More specifically, for a specific position that's for outreach purposes and for access and linkage to services as well. I know it's not necessarily a direct service, right? But I do want to just highlight that that was something that was taken into consideration as far as data goes, for that Humboldt application as well. So I just wanted to mention that too.
Thank you.
Could you repeat what you said Queer Humboldt's affiliation was at this point?
Yeah, it's they were approved for a local implementation agreement, which is part of our PEI program. And basically this upcoming fiscal year, they're going to be doing some outreach work for us as well. Funded by MHSA.
Okay, thank you so much.
Yeah, no problem.
Thank you. Other comments, questions, clarifications?
That was an incredibly clear PowerPoint presentation that showed, I've seen it so many times these past 3 years, but that was a good presentation, and I love seeing how you laid out all the information. Thank you.
Appreciate that.
Time for comments, Strash.
Yeah, I have a couple, and I mean, this MHSA, I mean, there's so many needs out there. It's always scrambling, you know, for what's more important than something else. And I understand that that's a real challenge for the HHS and the community. But I want to throw out a couple of things that at least, you know, that be given some consideration. And I don't even know if the funding, you know, some of this, I'm not sure funding can come out of MHSA, but just in case it can, one of them is to expand mobile crisis to homes with private residences. We go to the hospitals. That's something that, you know, it provides some pressure relief for SV and also for the hospital, but it doesn't provide any pressure relief for homes, which sometimes have extremely volatile things that are going on. And they're not likely sometimes to be resolved by voluntarily accessing at one of those other service points. And it does happen some places where they do go to the residents, and there's opportunity for de-escalation and referrals that be nice to look at. Staffing can be an issue. One way to deal with that might be, you know, just on call with bonuses, because it's not like it happens tons and tons, but it happens, and when it happens, it's bad. The other thing is to consider if this is a allowable use of MHSA money to partner with community hospitals to improve the facilities, particularly for juveniles, have a safe and therapeutic environment in an ER. And the other possibility that could happen is working with them to have site emergency rooms. It might be a collaborative thing where it might be just one of the hospitals. I know we're talking about doing that in Arcata, but there might still be some potential where it would be helpful. The other one is to structure our specialty mental health programs in small rural communities so they can be accessible to not only youth that have Medi-Cal, but also youth with private insurance. And I don't know if that's happening now, but some years back it wasn't. And that sometimes can be a problem, especially with specialty mental health, because it's set up for Medi-Cal. It's my understanding anyway. Have to be corrected. A fourth one is continue to look at facilities for co-occurring, and both for youth and for adults. We tried to do that some years back, and there's an issue with having folks that are in like for substance abuse only. Sometimes sociopathic behavior, along with people that can be very vulnerable, you know, that are on medications, have cognitive issues, and trying to continue to work for facilities that are specifically for people that are there for primarily mental health, I guess, or program would be something to look at. Again, I don't know about the money. The other one is probably the most important one, I would think, for me, is to move some of the funding for AOT to do it with MHSA. It's currently funded with general fund money, and that general fund money is, you know, here today, gone tomorrow. And AOT is a very legitimate use of MHSA funds. And if it's just, well, I won't go into details, but both AOT and the AB 43, those clients are, one of the problems is that they suffer from anosognosia, and so they don't know that they're ill. You know, they're not aware of that, and having a constant sustainable funding source for those folks would be long-term a benefit and a cost saver. Anyway.
Thank you, Jim. Those are close to my heart. Other comments? Yes.
I just want to appreciate one of the things that you brought up, is the value there would be in like a mobile outreach for families for in-home. Having a son who fortunately now he's willing to receive care, but for a long period of time he wasn't, and desperately needed it. And if there, you know, were an opportunity to have somebody come out to the house and communicate with that person, and offer like support in home and to, you know, the person in crisis as well as the family, that would be amazing. And the one story that you brought up of the young man who ended up stabbing his brother, like there, you know, just the possibility of there being somebody there without him needing even to be taken out of his home, but to have the support present.
Thank you. That is very important to know. Because we know how many times those crises happen in our homes.
Yeah.
They happen in our homes, you know. And so to have someone say, how do I get help? And someone to actually come out and do the best they can to guide or provide services, we think is a really critical thing. Thank you. Yes, Alyssa.
I want to jump on too. What about adding services or training for clinicians concerning people living with disabilities? The last time I went to receive services at mental health, I was told by the clinician that they had no training in how to help people who were on the autism spectrum, and told I would probably benefit if I went somewhere else. So I would like to bring up the fact that there might be more we can do for the disability community.
Good point. Other comments, questions? I've said this before, shared this with Emmy and others. I would like to see a clarification and an emphasis on therapeutic counseling. Because when we talk about, you know, treatment, we have a lot of different things. And peer coaches and social workers, case managers don't always have those skills. I was glad to hear from Jessica CCG about how many counselors and how they are overwhelmed. But I think therapeutic counselor would be an important thing to add. Someone to go see and say, I'm bipolar, what do I do about it? Talk about it, just try to work that out, because that's particularly at severe levels. All right, yes, Steve.
Yeah, I didn't notice a connection to housing in the report. There's a talk about the need for professionals and different things and stuff, but one of the big problems with getting that is housing. So I don't know if it's appropriate at some place in the report to maybe talk a little bit about the lack of housing, in particular for professionals that come to our community. We're losing all our specialists. So I think we all know that. And part of it is housing. So not that we can solve that one really quickly either, but maybe a little note in there on that. I think that's really.
Thank you. Are we getting ready to wrap this up? Then I'll kick it back. Back to you. Do you want to summarize and wrap up? Yeah, you.
Oh, do we? Okay, cool. All right. Well, everybody, thank you so much for, again, for hosting this, my very first public hearing. Again, I really appreciate your patience and your guidance in this matter, and I look forward to continuing working with you. And I'll see you in November again for another stakeholder meeting or annual update.
Thank you for being involved with the board for a long time. We appreciate you engaging us and including us as much as you can. So then I'm going to wrap up the report again with many of us great positive and gratitude for your work. Thank you. Yes, thank you. So we've already done item 7. We moved that up, and that's the Community Service Awards. Number 8 is an opportunity. As I look at my clock, we have about 7 minutes. So some communication from board members, and we'll see how many others we can do. Yes.
Parking out here is only for 2 hours. And every time we come in here, I get here at 12, so I'm early. And then by 2:15, that's 2 hours and 15 minutes. And I'm concerned, I can't afford a ticket.
Oh, yeah.
So I don't know if we can do something about.
Here's what I've been told by Michelle, who's the front receptionist up front. The police, your police are kind of lenient for those who participate. That's all I know. She said that informally. But what would we do? We could have shortened the meeting.
Yes.
We have done that in the past, but we felt like we needed more time, like today.
Right.
So let's have that conversation,
Okay.
you know, and I'm not sure what the answer is.
I was hoping that today that the Eureka Police Department could maybe fix any tickets.
Just take care of that.
Yeah, take care of that.
Just so you know, there
You
is.
can do that? That's great, thanks.
There is no, just for right now, there is no parking enforcement person. Don't let that get out, but it can change at any moment. So I'm saying today you're safe.
Okay.
All right, our secret, everybody.
Okay, thank you.
Yes, Colleen.
I'm intensely interested in hearing if there's been any update on the navigation center and the airport.
We have it on our agenda as a regular item. I'm not sure we can get to it this time. Okay, and Jack, but thanks for that sharing. Anything else from board members? Yes, Steve.
2 blocks out is restricted to 2 hours.
I'm already well blocked up. I just need one more.
One more block.
Did you say 32 hours? I hear it wrong. Anything else? So, let's see if we can fit in a report from Emmy at this time, and I don't see Connie with us, so we'll go to the director of the Behavioral Health Department.
I don't see Connie either, and I'm happy to say a few things. I actually have two things I'm gonna say. One is more technical and maybe less interesting, but just relevant. We're in the process. I spoke at the board about this, I think on Monday, of transitioning to a new payment structure, payment reform. It's part of CalAIM. It's one of the initiatives, and it means that we'll be able to get reimbursed for services or paid for service as a fee for service rather than cost reimbursement or through a cost settlement process. It really looks to be a helpful thing, and it's a ton of work for staff to get it on board, to get a new electronic health record on board. And so I have a lot of gratitude for staff doing that work, and it's just kind of a transition as part of many CalAIM initiatives to better serve our community and those with Medi-Cal that are experiencing mental illness and substance use disorders. The second thing I want to say is just kind of tagging on to what I think I first heard Leah lift up, so was said probably from the CSEP team and others. Humboldt County is doing really good work, and I'm just so proud of the partnerships that we have with our community and providers and other organizations. I think just in the last year, maybe, I have been so grateful and impressed with how we as a community are kind of coming together and speaking to the importance of caring for our community in non-stigmatizing and non-discriminatory ways. Like, we're really, I think, changing our language and talking about mental illness as part of the whole person, which I say that all the time, but I just can't emphasize enough that I feel like our community is really embracing that and struggling with how hard it is to meet the needs. Like, we're doing so many things and yet still feeling like we're falling short day after day, but continuing in lockstep to try to find ways to do better by our community. So I want to say that because I'm grateful for this board. I'm grateful for our community partners. I'm grateful for the board of supervisors. And I just feel like that needs to be said in addition to all the other challenges that we're often talking about. So thank you all.
Thank you. Thank you.
Do you have anything to add on the navigation thing?
That's not my area, so no, but we can talk about it at a future meeting for sure.
Yeah, that's been pretty much Connie's thing to carry.
Connie has that, and I think Hannah is the consultant. I'm looking for Laurel, who knows more, even more than me, but yeah, I think Connie could probably bring that.
Yeah, she did great presentation. I don't know if Hannah's available to come and update us on that sometime.
I don't know that Hannah would be the one to come and update until we were definitely further along. I think that we're getting close. We're getting close to more information and more groundbreaking or potential dates.
Got it. That makes a lot of sense. Thank you. And the actual operation, how it's going would be.
I know, and we will definitely want Connie to be able to be the one to say it, since she's worked so very hard for it, but I think she'll be able to let you know soon.
Yeah. Thank you. Any other things from committees? As the chair, always have a lot to say, but nothing to report. And so want to make sure we have the time. My watch says we have about another minute left. Does anybody have a good joke? No jokes. Okay, then,
Wait,
that was a joke.
that wasn't long enough. People 5 seconds to think of a joke.
Yeah, I can never remember the good ones either, so, all right, plan for the next meeting.
Okay.
Thank you, everybody. The meeting is now adjourned. We can hang around and talk to each other if we want to, but the official meeting is adjourned.
Thank you.
Thank you.
Yeah.
No.